Hi guys, this is Jody, and this presentation will cover part 2 for coronary artery disease. So you guys should have reviewed the Pearson book and watched part 1, and we are going to continue on here. So we'll talk about clinical manifestations. So it is important to know that you can be working in any type of setting and end up caring for a client who is having a myocardial infarction, because it is often the first sign of coronary artery disease. And I think I mentioned that in part 1, and I said coronary artery disease twice instead of MI. So let me clarify that statement again. So a client who is having an MI, we want to know that that is often the very first sign of coronary artery disease. So people can be walking around with coronary artery disease and have no idea that they have plaque buildup in their coronary arteries until all of a sudden they have a heart attack. Okay, so recognizing risk factors and teaching prevention to all clients, regardless of your clinical setting, is important. So if you recognize those risk factors, you want to address them. You will discuss more about dysrhythmias in 222, but you should be able to recognize ST elevated MI, or some people call it a STEMI, which we talked about in part 1. And we will talk more about pump failure or heart failure when we discuss heart failure later on in the semester. And then I will discuss pericarditis and Dressler syndrome on the next slide. So pericarditis is inflammation. So right, we hear itis. We should be thinking inflammation. It's inflammation of the pericardial tissue surrounding the heart. It is a complication that can occur after an MI or after heart surgery, and sometimes you will have patients admitted to the hospital with a primary diagnosis of pericarditis. So you should be able to recognize it by its symptoms. So a patient will have some chest pain, and the pain can be aching or sharp or stabbing in the chest, but is generally worse on inspiration. So if you think about it, if you think of the lungs expanding and pushing the heart forward towards the sternum during inspiration, that heart is pushing up against the sternum, and that can cause some pain. Like I said, it's inflamed. You would hear a friction rub. So when you're listening to the heart sounds, you actually hear a friction rub, which sounds very similar. And you guys can go on to the computer and search like a pericardial friction rub on YouTube, and you can find videos where they'll play sounds. They're not the best, but it'll at least give you an idea. Once you hear it, you will have always heard it. You'll know what it sounds like when you're hearing it. But instead of like that lub dub, you hear a rub. And if you were to like think of a balloon that has air in it, like you have an inflated balloon with air in it, and if you were to take your thumb on the outside and rub it down the outside of that rubber balloon, you kind of get that rubbing sound, and that's kind of what it sounds like, if you can think about that. But again, you have inflammation, and so what we're treating that inflammation with is generally anti-inflammatories. Okay, in general, this is not a medical emergency. Again, not a medical emergency. We would treat with anti-inflammatories like an aspirin or an ibuprofen, or we could treat with a corticosteroid. Okay, so we treat the inflammation. So Dressler syndrome is thought to be an autoimmune disorder. It may occur for several months after an MI, where the patient just for a prolonged period of time has this like chest discomfort. They might have fever, a little bit of dyspnea. It also involves some pericarditis, so you can hear that friction rub. If that fluid buildup around the heart, they have this pericardial effusion, is more severe and they're more symptomatic, then they can do a pericardiocentesis. So they might treat with that if the anti-inflammatories aren't working or with that. But otherwise, it just kind of wait until it resolves on its own. So when perfusion is impaired, I want you guys to think outside the box. In other words, think outside the heart in and of itself, okay? So this is just a reminder to think about the impact the heart has on the rest of the body. So if the heart is not working properly because it's not getting perfused properly, it may not be able to perfuse the rest of the body effectively. And of course, we will talk more about that when we talk about heart failure. But if you think about the symptoms, if perfusion is impaired overall, you might have skin that is cool, clammy, pale. Capillary refill time would be prolonged because it takes longer for the blood to travel, because the brain requires a lot of blood and oxygen. If that's not perfused properly, you could see changes in level of consciousness or confusion. The client may be lethargic. If perfusion is impaired to the kidneys, we could see a decline in kidney function. So it's important to think, again, outside the heart to the impact on the rest of the body. So collaboration, we want to teach smoking cessation, we want to manage blood pressure, strive for healthy BMI, manage cholesterol and diabetes, encourage activity. Again, American Heart Association recommends 30 minutes a day, 5 times a week. It's actually 5 to 6 times a week. Teach stress management, provide diet teaching. We want individuals at risk eating a heart-healthy diet, which includes fruits and vegetables, lean proteins, foods low in saturated fats, higher in fiber. Pay attention to women who have risk factors and are taking oral contraceptives. So once a client has been identified as having coronary artery disease, which is usually diagnosed when a client is having chest pain or angina. Remember, angina is that chest pain that is related to the heart itself, okay? Or has had myocardial infarctions. The goal is to manage pain, reduce cardiac damage, which requires a quick response. And I have this in here to video of rapid response for MI. Will remind me, because we will talk about that in class, and I'll have a video to show you for that. It's because we want quick response. If a client is having an ST elevation MI, we know that time is of the essence. We want to treat that ischemia so that we can get that part of the heart muscle perfused so that we don't have permanent damage. Okay. There are clinical areas where collaboration will occur for clients with coronary artery disease. So we'll think about a patient who is on a med-surg unit and then develops some chest pain. So what we would be doing for that patient is looking at, the patient has, chest pain, they're on the med-surg unit. The first thing that you guys would want to be doing is, of course, notifying the doctor and then getting that EKG, because that's what's going to be ordered. They're going to say, get an electrocardiogram. They may also say to you, we want to check some troponins to see if the patient does have cardiac damage. Okay, so those are diagnostic tests, because the most important thing is for us to know, is this patient having an ST elevation MI right now? And if they are, if you guys do that EKG and you see those ST elevations, what generally will happen in the hospital is they'll call a rapid response or an MI team, okay, so that then they can get that patient to the cath lab. Okay, so diagnostic tests that you would be doing right at that moment that the patient has chest pain is an EKG, and then you would be drawing off troponins. Okay, generally troponin, they'll do 1. If that's positive, it's positive. We really don't track. They used to do them serial troponins every 8 hours times 3. Some hospitals may still do that, but if you get the first one back and it's positive, the patient has ST elevation MI, then we know that they need to get to the cath lab. Okay. Other diagnostic tests that we would be thinking about for clients that have coronary artery disease would be cholesterol screening, because we now want to look at our risk factors. Okay, does this patient have high cholesterol? Do we need to address that? The other thing that we can be doing for a patient is an echocardiogram, which is an ultrasound of the heart. We'll talk about that more with heart failure, because basically when they would be doing that is if the patient has had an MI, they've gone to the cath lab, they come back, we want to know, did they have tissue damage? What is the contraction of the heart looking like now? So we'll talk more about ejection fraction when we talk about heart failure. But ejection fraction really is looking at the pump function of the heart. How well is it perfusing the body overall? So a normal ejection fraction is anywhere from 50 to 70%. I usually say right around 60% is what's being ejected out of the heart to the rest of the body. The echocardiogram is a quick, non-invasive test that can really look at that to determine what the ejection fraction is. Those are the big ones, I would say, as far as diagnostic tests. Hemodynamic monitoring, we'll talk about more in 222. So we'll say that this patient, they had an MI from the med-surg unit. They went right to the cath lab. They got a stent placed. We'll talk more about stent placing in class. We're going to talk about revascularization, so we'll talk about that there. And now you have a patient who, we'll say that they're going to be conservatively managed. Or let's say we did the EKG on that med-surg floor, and maybe they had a non-ST elevated MI. It didn't need to go to the cath lab. It doesn't really matter. But basically, the patient is not going to be a good surgical candidate. We want to conservatively manage this client. So conservative management is going to be the less invasive. It's a less invasive type of management, and really what we're doing is targeting the risk factors. So, if the client is smoking, we want to talk about smoking cessation. We want to talk about diet with the patient if they're not already eating a heart-healthy diet. We want to talk about exercise to be healthy. If they're hypertensive, we want to manage their hypertension. If they're diabetic, we want to manage their diabetes. So when you think about conservative management at baseline would be diet and exercise. Right? There's no intervention other than diet and exercise. Still conservative management as we get into medications, if we need to give those. And then as we get into more invasive would be surgical procedures that would do for that. But, if you had a question, on an NCLEX exam which said, was talking about conservative management, you're going to go with the interventions that really target risk factors at first without giving anything. If we can target, diet, exercise, really changing their lifestyle. And then, like I said, it's still, if we have to give some meds to do that, it's still fairly conservative, but it's going to be more invasive than just changing diet and exercise, if that makes sense. If not, we can talk more about it in class. You guys can ask questions. So smoking cessation, reduces the risk by 50% within 1 year of quitting. So if you remember from part 1, I talked to you about that patient I had who wanted to go to his daughter's wedding, which was a year after he had been in the hospital. Well, that's a good thing that I can teach the patient. If he says to me, I don't want to quit smoking. Well, listen, you said to me you want to go to your daughter's wedding. You want to walk her down the aisle. What if I tell you that if you quit smoking now, that your risk is decreased by 50% in 1 year. That's huge. That's really a huge reduction of risk when you think about that. So really kind of using that as a motivator. Smoking cessation may also improve cholesterol, and it also reduces blood viscosity. So your blood is going to be thinner. It's going to flow better. It just, overall, there's such a benefit to quitting, really. And then diet, so fresh fruits and vegetables. Avoid processed foods. And, heart-healthy diet is generally good for everybody. These are not patients. And even though, you might have a patient that you want to reduce their BMI, they're not patients. We're going to say, hey, go on a keto diet. Because those keto diets tend to be high in fat, high in cholesterol. A lot of people that do those keto type diets don't do them in a healthy way. So really the teaching that we're going to be doing is, especially even if they have to lose some weight, is fresh fruits, fresh vegetables, avoid processed foods. They can reduce their caloric intake if they want to lose weight. They can increase their exercise if they want to lose weight. But we're not doing those fad diets that can, you got to be really careful with those, like the keto diets, okay? So good meats for patients, chicken breast, fish, lean beef. The way they cook their meats is important, right? So grilled is going to be the best way that they can do it. If they're going to saute their meats at all, we would say maybe with a little bit of olive oil, which is a healthier fat. We want high in fiber, so oats are good. We want them to avoid foods high in sodium, which will increase their blood pressure by increasing the fluid volume they're keeping in their vascular system, so low sodium foods. And usually I have them start by just getting rid of the table salt and then starting to target other foods. They should be getting their carbs from fruits and vegetables and greens. They should avoid canned foods and eat more fresh, like I said, fresh vegetables. The book states alcohol in moderation, but how will some clients define moderation? And that's important to ask your clients too, because they might think that 2 drinks a day is in moderation. So that might be something we need to teach and discuss with patients as well, is their alcohol consumption. And again, weight loss, if they need to decrease their BMI, would be through a healthy diet and exercise. So exercise, again, American Heart Association recommends 30 minutes, 5 to 6 days a week of moderate intensity. So, you'll have some patients that'll say to you, well, I get up and go to the bathroom a gazillion times a day. Like, that's my exercise. No, that's not exercise. Exercise is maintaining that heart rate up for a good 30 minutes. So a nice walk, a nice brisk walk, if that's all they can do. And listen, if they can't walk fast, it doesn't matter. I mean, as long as they're getting up and they're getting their heart rate up for 30 minutes, whatever it is that they're doing, that's a good exercise for them, because it's going to take time to build endurance if you're somebody who's never really exercised before. If somebody wants to lose weight, it may be 60 to 90 days of moderate intensity exercise, 5 to 6 times a week daily, or 5 to 6 times a week. So it really depends on the patient. We look at the patient, but again, exercise is important, and we would never tell somebody, oh, you just lay around because, you have heart disease, you can't do much. Okay, we want patients to have quality of life. We want to improve their heart function. So we want to manage hypertension. We can do that by having them reduce sodium intake, regular exercise, stress management, and then if they are on medications, taking their medications as prescribed. So lisinopril, your ACE inhibitors, are generally your primary drugs that they will give for blood pressure management. Some patients don't tolerate them well because they will develop that dry cough that some can develop with the ACE inhibitors, but that's generally what they're going to start them off with, is an ACE. Diabetes management is important, so we want them, if they're diabetic, checking their BGs regularly, and if they're on medications, taking medications as prescribed, and then also teaching them, reinforcing teaching. Don't just always assume that patients know. Like if they're diabetic, you think, oh, they know what they should be eating. They've been diabetic for years and they take these meds. No, we can always reinforce teaching, and we might say something that sticks at some point. So we'd still be doing some diabetes teaching with patients. So pharmacology. So you guys have a large med list that I gave you. You definitely want to look that over. I know there's a lot of meds on there for perfusion. So, students always ask me, well, which ones do I focus on? Well, they're all important. Okay, we want to target cholesterol. So if we talk about the statins, those are important. We will talk about nitroglycerin. That is really important for coronary artery disease. Because we're talking about blood pressure management, those ACE inhibitors are important. So if we've talked about them in class, if I've talked about them in the prep, they're very important for you guys to know. So there is a worksheet. If there was any information that wasn't in the book or you couldn't get from the book, I added that into the worksheet. I think most, if not all of the rest of them are all in your Pearson book. So if the Pearson book didn't mention something, then, and I think it's important, I did mention it. So like I added on there for your nitroglycerin that it does cause headaches for patients, and that's important to be aware of, that if you administer nitro to a patient, they might develop a headache because of that vasodilation. But anyway, so just make sure that you're reviewing that med list, go through that med list, look at them in your book. If you have questions about the meds, let me know. And that's it. So if you guys have questions, please bring them to class. What we will be talking about in class is revascularization. So we will be diving into coronary artery bypass grafts and angiograms and angioplasties. And then again, one of the big complications of somebody who has an MI, if they have a reduction in their ejection fraction because of that tissue death, you can have somebody going into heart failure. And we will be talking about heart failure, I believe, in week 3. So that will also be on exam 1. So stuff to talk about. So please just make sure that if any of this was confusing, if you had questions about the readings or the that cholesterol website or any of the prep work, please bring those questions to class. We will do a quick review, just answering questions, clarifications of this information, and then we're diving in and moving on to revascularization. Okay, so I will see you guys all in class.